So now we have two adjuvant therapies that have been studied in phase 3 trials, pertuzumab, of course, up front, and neratinib out back, or as extended adjuvant therapy. What's interesting is that on subset analysis of the trials, it looks like different subsets benefit. So pertuzumab seems to benefit patients who have node-positive ER-negative disease, and so at least you know that if you took your higher risk patients with ER-negative disease, that's where you're going to get your biggest bang for the buck for pertuzumab. In contrast, neratinib had its biggest buck in higher risk patients with ER-positive disease in subset analysis. So it's my expectation that that's exactly what we're going to do moving forward. Again, with the caveat that we don't really know how long we need to treat patients. We don't know if you need to continue pertuzumab for a whole year. We certainly want to start neratinib as close to the end of the first year of trastuzumab and or pertuzumab-based therapy as possible. But it does seem to me the patients in the Affinity trial overall did very, very well. I mean, the bottom line is outcome was very good. And so if you take a low-risk population with a little over almost 4 years of follow-up, that those patients are going to overall do well. So when we're adding new drugs, we do want to select the patients who have a higher risk of recurrence and understand the subsets with all the caveats of subsets, that it does appear that these agents work differently in different subsets of breast cancer. I think it's really important for us to control diarrhea when we are giving pertuzumab to patients who are also getting docetaxel and carboplatin, and to make patients aware up front and potentially to prophylax. And for patients who are receiving neratinib, the prophylaxis is critical. Everybody should receive prophylaxis. The optimal prophylactic regimen is still being determined. I think that the neratinib area, the whole incorporation of neratinib into our treatments is going to be interesting. We're going to see results in the not terribly distant future from a trial called NALA, which is looking at lapatinib and capecitabine versus neratinib and capecitabine, and it's the best comparison of neratinib to a standard approved regimen in terms of a phase 3 trial that exists. So, I mean, the other trials were not really, they were comparing apples and oranges in a way. So it'll be interesting to see what happens. And of course, there's prophylaxis for diarrhea, that the understanding is much better about how to manage diarrhea. And both of the oral tyrosine kinase inhibitors cause at least some degree, lapatinib less than neratinib. So that data, I think, will be really helpful for us in understanding how to use neratinib in the metastatic setting. And then I think that the least amount of prophylaxis you should do with neratinib is the loperamide up front. And what you do is you gradually taper down. So we have generally prophylaxed for the first 2 months in the control trial, but that beginning is critical. You really want to get patients prophylaxed up front, because if they have terrible diarrhea the first day, they're going to be very discouraged. So you help people to understand that the diarrhea occurs early. If we control it early, we can start getting rid of some of the prophylaxis over time, but you're always going to have to be aware of it as a risk. So it may be induced by diet or having a viral infection or something like that. So we do want to balance that out. But I think that education on part of the providers and the patients is going to manage this reasonably well. There will always be a patient that can't tolerate an agent. So in that situation where you've used prophylaxis, the patient can't manage the drug for whatever reasons, you do your best, But most patients will be able to tolerate the medication, I think, with this approach.